Okay, so good morning, everyone. Thank you for allowing me to present this talk on the standards of care and management in children with eosinophilic esophagitis. It's a battle, really, to manage and treat children with eosinophilic esophagitis. But I want to present to you a more interesting battle that generally happens between my two colleagues, Dr. Miqdadi and Dr. Amer. This is an ongoing battle in our department on who is the fittest and who is the strongest. And yesterday we witnessed some of these battles, and I'll leave it up to you to decide who won. And so I'm going to now go to the more boring part. Dr. Miqdadi and Dr. Amer make my life in my department extremely enjoyable, and they make me happy to come to work, because in a very busy tertiary gastroenterology unit, this is really what makes you happy and makes you want to come to work. They are great men to work with. Okay, I have no conflicts of interest to declare. And I'll be talking to you about the background history of eosinophilic esophagitis. We'll define it, the pathophysiology, how do our children present, how can we diagnose them, and how to treat them. So the first description of eosinophilic esophagitis was about 30 years ago. So I think it is younger than most of the people sitting in this room. And it was appreciated as an entity and defined as a specific disease in 1995. And since that, we are seeing more and more children diagnosed and adults diagnosed with eosinophilic esophagitis, and the prevalence has increased over time. And the overall global prevalence is estimated to be about 50 to 100 per 100,000 people. And it wasn't then these patients who were diagnosed, or this entity, they felt that these are patients with gastroesophageal reflux, but they were not responding to conventional treatment. So they started to realize in their biopsies there was an increased number of eosinophils. And it wasn't until 1995, again about 30 years ago, where they started to link that this disease is not reflux and it is an entity related to the diet. So they had 10 patients that were not responding to medical treatment. 6 of them had actually anti-reflux surgery, and none of them improved. So they put them all on an elemental diet, and all these patients had eosinophils on their biopsy. And there was a clear improvement within 6 years in their symptoms and in their histological findings, with most of them a clear drop in the histology. And when they reintroduced diet, their symptoms recurred. So they concluded that eosinophilic esophagitis is an allergic phenomenon, and it improves with food elimination. And it was later diagnosed, and we have a definition, which is a chronic inflammatory process. It's an immune antigen mediated of the esophagus, and it's characterized by 2 things. You need clinical symptoms related to esophageal dysfunction, in addition to your histological findings of eosinophil predominant inflammation within the esophagus. But the more we learned about this disease, the more the definition changed. So initially, when it was first diagnosed, the 2 diseases, reflux and eosinophilic esophagitis, were 2 distinct conditions. So to diagnose eosinophilic esophagitis, you had to rule out reflux, either by giving your patient PPI and making sure he doesn't improve with PPI, or doing a pH monitoring. In 2014, they decided that there's not just 2 entities, there's 3 entities. So you either had reflux, or you had allergy, or you had yet another 3rd condition, which is called PPI responsive esophageal eosinophilia. And the definition finally changed in 2018 with more research and with our understanding of the disease. And they actually decided that these two entities, gastroesophageal reflux and eosinophilic esophagitis, can coexist. Because if you have eosinophilic esophagitis, you can have secondary gastroesophageal reflux associated with it, because eosinophilic esophagitis does affect your compliance and motility, and vice versa. If you have gastroesophageal reflux, this affects your permeability and the barrier integrity, allowing antigen exposure and then subsequently development of eosinophilic esophagitis. So now we know that these two conditions can occur together, and there's a relationship between these two diseases. So in clinical terms, how can we diagnose it? Well, you need to have clinical symptoms of esophageal dysfunction in addition to pathology. We need to have pathological evidence with one biopsy. You only need one biopsy with more than 15 eosinophils and inflammation. You need to make sure there's no other GI involvement, the stomach or the duodenum, and you need to exclude other causes of eosinophilia. The pathophysiology, we know there's an allergen. Your lumen, the GI, the esophagus gets exposed to an allergen. This creates an inflammatory reaction with influx of eosinophils. There are inflammatory mediators such as interleukin-14, interleukin-13, and interleukin-5 involved. There are inflammatory cells, including Th2, beta cells, of course, eosinophils, and basophils and mast cells. This creates an inflammatory process. This inflammatory process will cause your symptoms of esophageal dysfunction, and if left untreated, will cause fibrosis. And once you have the inflammation, you will start getting the symptoms. And with children, eosinophilic esophagitis, the presentation is variable. The younger children will have feeding disorders and vomiting, and the older children are more likely to present with food impaction and dysphagia. And so when you see these children that come to you in clinic, please think if they have reflux symptoms, if they have vomiting, if they have nausea, abdominal pain, food refusal, and the younger ones with failure to thrive, if they're not improving with your conventional treatment, think about eosinophilic esophagitis. The older children, if they have dysphagia and food impaction, I think these patients deserve an endoscopy. And of course, the children who have pain in the chest. We know that there's a male predominance of this disease at all ages. Males are 3 times more likely to have it. And we know that there is an allergic relationship. Children who have eosinophilic esophagitis are likely to have other allergic diseases. The most linked allergy is food allergy. So any child who has food allergy is 9 times more likely to develop eosinophilic esophagitis, but allergic rhinitis and atopic dermatitis and asthma also carry an increased risk. So again, when you see these allergic children, you have to, if they have GI symptoms, think about eosinophilic esophagitis, and the other way around. When we see children with GI symptoms, we ask about atopic symptoms such as eczema, asthma, and hay fever. And when we think this is the problem, we have to diagnose them. So the diagnosis is based on endoscopy and histological tissue. Changes that we find on endoscopy are furrows. We find white plaques. We can find rings and trachealization. And if left, and this child has the endoscopy late, we find strictures. Strictures can lead to food impaction, and we do get the emergencies with children with food impaction. Even when you don't have a stricture, you can still have food impaction because of the motility problem. If you see more than one change on your endoscopy, this is quite sensitive and specific to eosinophilic esophagitis. It carries an 89% sensitivity, 87% specificity. There's a scoring system, and this scoring system really is that's been developed called eosinophilic esophagitis endoscopic reference scores, looking at all these changes with scores from 0 to 2 on the level of inflammation and the severity. And there has been a correlation. The endoscopic scoring system is related to the peak level of eosinophils, and the treated patients will have a lower score than the untreated with statistical significance. We always have this debate where to take your biopsies from, how many biopsies to take. Well, the higher biopsies have a better sensitivity than the lower biopsies. And if you take upper and lower, you have a higher diagnostic sensitivity. And the recommendation is that 6 to 9 mucosal biopsies will give you a near 100% diagnostic sensitivity, and only 1 biopsy gives you only 55. So we tend to, when we scope the children, take at 3 different levels, lower, mid, and upper esophagus, and we take at least 6 biopsies. And under the microscope, you have to look for the changes, which include, of course, the increased number of eosinophils, but you also need inflammation. We need more than 15 eosinophils. We need, there's the basal layer of the esophagus. There will be thickening, as you can see here. And there will be increased in the intracellular spaces, as you see by the white arrow. So these changes, we need to find them when we get our histology to diagnose the patients. So how do we treat them? I'm going to present to you one of my patients, Abdullah. Abdullah came from Fujairah for treatment. He was referred to me by his allergist. He was seen by the allergist because he had some GI symptoms, and because they did a skin prick testing, which was positive to milk, wheat, soya, almond, hazelnut, pistachio, even sesame. But this child actually eats all these products and does not have anaphylactic type 1 allergic reaction. But he has abdominal pain, he has vomiting, he has atopic dermatitis, and he was already on PPI high dose. So it's a no-brainer, really. This child needs an endoscopy. So we did an endoscopy. He had classical endoscopic findings and did have eosinophils at all levels, more than 20 per high power field with inflammatory changes. The stomach biopsy and the jejunal biopsies were normal. So we discussed the treatment options. The first option is dietary treatment. Then we go to medical treatment. This child did not have a stricture, so he didn't need any endoscopic intervention, such as esophageal dilatation. I discussed with the mother and the father the options. There are 3 ways of implementing dietary treatment. We can either go for allergy-based elimination based on his skin prick testing and if he had patch testing, or we can do an empiric food elimination, and I'll discuss that in a bit more details, or we can go for a full elemental diet. When you see these patients, you have to have collaboration with an allergist, because you need also these patients to be managed well with their other atopic diseases, and we collaborate really closely when we choose food elimination and food reintroduction with the allergist. You need a good dietitian, and there is a risk of de novo IgE-mediated allergy if you exclude a certain food and then later reintroduce it. So you need an allergist to be involved with their care, because they can develop an anaphylactic reaction. So what about food exclusion? I had my IgEs, I knew, my skin prick testing results, I knew that there were some foods that I can eliminate and I have options. Well, we know that eosinophilic esophagitis is not an IgE type 1 hypersensitivity. It's a IgG rather than an IgE. So the evidence shows that in children, it works in less than 50% of patients. And actually, the recommendation is not to go for food elimination based on your allergy testing, just because the allergy tests are IgE mediated and we are dealing with a different type of pathology. How about food exclusion? There are different ways of empiric food exclusion. You can do 1 food, 2 food, 4 food, or 6 food exclusion. The 1 food exclusion is milk. Milk has to be one of the first one to be excluded, followed by wheat, egg, soya, nuts, and seafood. And there is evidence that the more you exclude, the more you get a likelihood of success of your treatment. But we all know this needs dedication and this needs compliance, or else you will not win and you will not improve the child. How about a food elimination diet with an amino acid meal? We know it works, 95 to 98% success within 4 weeks. Then you reintroduce 1 food at a time, but it is such a difficult type of treatment. And actually the recommendation is not to use this as first line and only use it if your patient does not respond to all other treatments as your last resort. So Abdullah's mom told me, my son's not going to comply. I'm sorry. Food, milk, no. He has to have milk. He has to have his yogurt. He has to have his dairies. I'm not going to be able to comply with this diet. So I think we ended up thinking about medications. Well, we know proton pump inhibitors can help, but the child was already on it and we needed something else. So our options are steroids, topical steroids, which we know can work. Antihistamines, leukotrienes, montelukast, azathioprine, 6-mercaptopurines have all been tried and they are not recommended to be used for treatment of eosinophilic esophagitis. And we have the biologics, which are new, that have been used, and we are getting good results from them. So I think we decided to put Abdullah on topical steroids and PPI. Proton pump inhibitors, just a quick slide. It does work in about 50% in children, but you need to give them at least 8 weeks. And the recommendation is to use a high dose and twice daily PPI. So we put him on budesonide, but you can also use fluticasone inhaler and swallow it. And there is clear effect and 11 randomized controlled trials and meta-analysis demonstrated that topical steroid does work for these patients. Some people think, so why don't we give oral steroids? Why topical? Well, there was a study that compared oral steroids with topical steroids, and they both did show histological remission within 4 weeks, but the side effects of oral steroids outweigh the use since they both work. And the recommendation is, because of the potential side effects of oral steroids, it is not used as first line and only reserved for when other topical steroids are not effective. So Abdullah stayed on steroids. We had an endoscopy. His symptoms were better. His endoscopy has fully healed on topical steroids. Then the mother is coming to me telling me, well, how long does he need to stay on steroids? Can't we stop the steroids? Is my son gonna stay for the rest of his life on steroids? And is there any other treatment options? Can I stop this and give him something else? I think till now, we know that I think this is like gonna be IBD, to be honest, eosinophilic esophagitis. We will have some minority of patients that will recover from this illness, but this is a chronic inflammatory process. And I think so far the recommendation is for long-term treatment. We have no evidence, this is my personal opinion, we have no evidence to say, to know for how long do we need to treat these patients. This is a fairly new disease and no one can answer this question. So I tend to keep my patients on it. What are the other treatment options where there is new hope on the horizon with biologic treatment? So dupilumab is an FDA-approved biologic, which is an interleukin-4 and interleukin-13 antagonist. It inhibits them. And it has been approved for children with eosinophilic esophagitis over 12 years old. We are awaiting approval for children above 8 years old. I have used it. It is available in the UAE. And I think I've seen quite good response to it. It is not our first line, but it certainly is helping these patients who don't want to be on long-term steroids, who are developing difficult difficult side effects from topical steroids, or on the ones who did not respond to it. And I've had really good results and really quick results. There are two other biologics that are not available in the UAE. One is still under trial and the other is used for severe asthma, but has not been approved for eosinophilic esophagitis. So there's so much we still need to learn. It's a very young disease, a very early disease, and we're still waiting for more data, more evidence on what to do with these patients. So in summary, I would like to tell you that eosinophilic esophagitis is a chronic immune antigen-mediated esophageal disease characterized by symptoms of esophageal dysfunction with histological eosinophilic predominant inflammation. It's increasing in prevalence. The symptoms are non-specific in early childhood, and children have other forms of allergy. We need to diagnose it with endoscopy and histology, and we have treatment options, including the biologics. We still have a lot to learn about this disease. And I finish really my talk with this amazing photo from yesterday's trip. This conference is not only about learning. We connect. I've met so many new friends, and I've rejoined old friends. And I hope we keep this conference going for years to come. Thank you very much.